Thank you for inviting me to speak on the subject of CVD prevention in type 2 diabetes. I will be speaking on primary and secondary CVD prevention, the new focus of type 2 diabetes management. As Omnicuris is celebrating Diabetes Awareness Month and is partnering with RSSDI for promotion of education regarding type 2 diabetes management across our country, I am very much delighted to be part of this CME series by Omnicuris, and I will be speaking on the CVD prevention in type 2 diabetes. So why it is important? Because type 2 diabetes is considered as a major risk factor for cardiovascular disease, and CVD is the most common cause of death in type 2 diabetes. Also, less than 50% of US adults with type 2 diabetes, they meet recommended guidelines for CVD prevention, and therefore it is very much important to expand the use of therapies which are very much used or proven to prevent CVD in type 2 diabetes. And with appropriate lifestyle and this CVD risk factor management, we can reduce the burden of type CVD among type 2 diabetic patients and thereby improve their lives. So that is the sole purpose that we need to focus on CVD prevention in type 2 diabetes patient. So let us start how it begins. So it is a common soil hypothesis that there is a glucotoxicity, lipotoxicity, inflammation, all these three, they contribute to insulin resistance, endothelial dysfunction, and they will result in a range of cardiometabolic disorders starting from obesity, diabetes, dyslipidemia, to atherosclerosis, hypertension, coronary artery disease, and ultimately cardiovascular death. As per the tickling clock hypothesis, the risk of macrovascular disease, it begins much early, even before the diagnosis of diabetes, as evident from this graph. So even when the patient is having mild dysglycemia or in the range of pre-diabetes, the risk of macrovascular complication, it starts increasing, and microvascular complications, they increase only when the hyperglycemia is set at the point of diabetes diagnosis. So macrovascular complications, they occur even in people who are at increased risk of diabetes because they are harboring other cardiovascular risk factors also, and therefore the risk of macrovascular complications increases. And this is very well highlighted from this nurses health study, in which the women were followed for a period of long-term follow-up was there, and the women who were non-diabetic throughout the study, as compared to them, the women who developed dysglycemia, not to the diagnostic range of diabetes, but before that also just mild derangement in blood glucose values, that was associated with almost 2 times higher risk of MI or stroke. So that suggests that even before the diagnosis of diabetes, mild derangement in blood glucose levels, they definitely increase the risk of cardiovascular events in the form of MI or stroke, as evident from this nurses health study. And the same is evident from this second study, where fasting plasma glucose, they have tried to correlate. They have included diabetic patients as well as non-diabetes at baseline patients. And if you see, when it rises above 5.6, the risk increases of coronary artery disease. So even in pre-diabetes range, the risk was increased by almost 12%. And when the fasting blood glucose was between 6.1 to 7 millimole per liter, it is almost 100 to 126, then the risk was increased by 17%. So this suggests that macrovascular complications, they start much earlier with mild derangement in blood glucose values. Definitely, once diabetes is diagnosed, the risk of vascular complications, it increases, particularly the macrovascular complications, either coronary artery disease or stroke subtypes or other vascular deaths. All this, they increase to the tune of almost 2 times in diabetic persons as compared to non-diabetic persons, as evident from that study published in Lancet. This is a beautiful study where they have tried to find out how many years they are lost when a person is diagnosed to have a diabetes, and that gives an idea that diabetes confers an equivalent risk to aging 15 years, as evident from this graph. And in general, younger people with diabetes, they do not seem to be at higher risk of CVD. So age should be an important factor when we are treating type 2 diabetic patients. Age should be an important factor, and duration of diabetes should be an important factor to consider whenever we are thinking of vascular complications or vascular death. Why type 2 diabetes is linked with cardiovascular disease, or dysglycemia is linked with cardiovascular disease? There are many factors which are playing role together. So there is dysglycemia, beta cell dysfunction, insulin resistance. There is inflammation is marked by all these inflammatory markers. There is dyslipidemia. We all know there is small dense LDL, HDL is low, free fatty acids are high, triglyceride is high, non-HDL cholesterol is high, and hypercoagulability. There is alteration in growth hormone system also. There is endothelial dysfunction, oxidative stress, and all this thing together, they contribute to high risk of cardiovascular disease in type 2 diabetic population. Now let us focus on CVD prevention. So this is a beautiful article which was published in Clinical Cardiology in 2018, that how can we go for CVD prevention at a population level. And they have suggested these three modes of prevention. First is primordial, second is primary, and third is secondary prevention. I think type 2 diabetic patients, they generally fit here in primary prevention because many of them, they are already having subclinical atherosclerotic disease. Primordial prevention, in people who are having traditional risk factors, you try to modify those risk factors and you try to prevent the development of atherosclerosis and cardiovascular events. That is being termed as primordial prevention. Primary prevention is already patient is having subclinical atherosclerotic disease. Now you are trying to prevent the vascular events, and that is being termed as primary prevention. Vascular events in the form of myocardial infarction or stroke or peripheral critical lower limb ischemia, resulting in gangrene or amputation or other things. Secondary prevention is people who have already developed clinical atherosclerotic cardiovascular disease in the form of either coronary artery disease or cerebrovascular disease or peripheral arterial disease or heart failure or resuscitated sudden cardiac death. So these are the patients where whatever treatment you do, you are trying to prevent further cardiovascular events, and this is being termed as secondary prevention. And on the top of the pyramid is people who are having recurrent cardiovascular events. These people are at the highest risk of subsequent cardiovascular events, and this is also being termed as secondary prevention. So this is about CVD prevention, the terminology is used, and how can we go for CVD prevention at a population level. The same thing says that you have to approach every patient for CV risk assessment, particularly every diabetic patients. If we see, this is for general population, but we can apply this to our diabetic population also. So assess for traditional risk factors, it is A, B, C, D, E. First you assess traditional risk factors, then you base risk estimation via various risk scores, then you consider non-traditional risk factors, biomarkers or non-invasive measures like coronary artery calcium score or ABI or other things, or left ventricular hypertrophy or presence of albuminuria. These are also non-traditional risk factors. Then you develop personal risk profile, and depending on that, now you decide that what is the risk of cardiovascular disease for a given person, and then you have to use therapies to reduce that CVD risk in that patient for prevention of cardiovascular events. So this is ABCDE approach suggested by that paper of Clinical Cardiology for approach to cardiovascular risk assessment and CVD prevention at a population and at a personal level. We all know the Steno trial, although the number of patients which were involved in Steno trial were very small, almost 160 patients were included in that trial. But the Steno trial was the first to say that multifactorial intervention is the key if you want to prevent cardiovascular events in type 2 diabetes. And what they have done, they have divided patients in two groups: type 2 diabetes with microalbuminuria. They have divided them in two groups. One group was given intensive therapy and second was given conventional therapy. And the targets were smoking cessation, achievement of ideal body weight, A1C less than 6.5, cholesterol less than 175, triglyceride less than 150, systolic BP less than 130, diastolic BP less than 80. And as evident from this graph, more people in intensive therapy, they were able to achieve a good cholesterol and blood pressure control, although the glycemic control was still poor. Almost 17% they were able to achieve in intensive therapy, but it was much better as compared to conventional therapy. And this translated into a lot of benefits. Over a period of 8 years, if you see, there was a reduction in cardiovascular events, that is composite endpoint of death from CV causes, non-fatal MI, CABG, PCI, non-fatal stroke, amputation or surgery for peripheral arterial disease almost 53% reduction. And at the end of 8 years, the trial was completed. And thereafter, the patients were further followed up. Although now both the groups, they were having better control of their risk factors. In spite of that, at the end of 13 years, further 5 years down the line, there was a reduction, absolute risk reduction of 20% in cardiovascular events in people who were able to maintain their risk factors control very well for the first 8 years of their life when they were diagnosed to have diabetes with albuminuria. This suggests the importance of multifactorial intervention in type 2 diabetes for prevention of cardiovascular disease. So these are the three main guidelines which we will touch upon in our presentation. First is the 2019 release ESC guidelines on diabetes, pre-diabetes and cardiovascular disease, which are developed in collaboration with EASD, published in European Heart Journal. Second is Canadian guidelines, which were published in 2018, that is cardiovascular protection in people with diabetes. And third is the ADA 2020, that is cardiovascular disease and risk management, which is published in January 2020. So I will touch upon few things. First and foremost, we will go to ESC guidelines. They say that CV risk assessment. So every diabetic patient, you should assess microalbuminuria. You should do a resting ECG, particularly when the patient is having hypertension or other risk factors for cardiovascular disease. Other tests, such as if we see echocardiography for estimation of left ventricular hypertrophy or coronary artery calcium score and ankle brachial index, it may be considered as a risk modifier. If the patient is, you feel that the patient is at intermediate risk, you may use this test to identify individuals who will benefit better from intensive strategy for CVD prevention. Routine assessment of novel biomarkers is currently not recommended for CV risk stratification in type 2 diabetes. As far as coronary artery calcium score is concerned, diabetic patients, they are having more calcification as compared to their age and sex matched subjects without diabetes. If score is 0, then the result, it is a very favorable prognosis. But as the score increases from 0 to 1 to 100 or 100 to 400 and 400 and more, there is an increase in mortality to the tune of 25 to 33%. One should keep in mind that high CSC does not mean that there is an ischemia. It suggests the future risk of cardiovascular events is high, future risk of cardiovascular death is high, and these patients, they benefit, as per the evidence, they benefit from intensive high-intensity statin therapy. Same way, ABI is associated with an increased risk of all-cause and CV mortality in diabetic as well as in non-diabetic subjects. So these two things one can use. And third is echocardiography for evaluation of left ventricular hypertrophy, also to identify heart failure with preserved ejection fraction with the help of echocardiography, which also gives you an idea about the future CV risk of that diabetic patient. So routine screening of CAD in asymptomatic diabetes is not recommended because currently the evidence is not there. If you treat all the risk factors in a proper manner, whether you subject them to an invasive coronary angiography and subsequent revascularization or not, the risk of cardiovascular events is not much improved by intervention. So therefore, routine screening of CAD in asymptomatic diabetes is at present not recommended because of the lack of evidence. However, in some of the cases, you may think of going for an invasive coronary angiography to find out coronary artery disease, extent of coronary artery disease. CTCA may be indicated in very high risk asymptomatic individuals who are already having established peripheral arterial disease or stroke, who have developed stroke, and now you want to identify subtle signs that the patient might be having coronary artery disease also. High CSE score, proteinuria or renal failure, these are the people where you may think of stress testing or other testing to diagnose coronary artery disease, and then if required, one may subject them to invasive coronary angiography. So as per ESC guidelines, diabetic patients, they are divided in three groups. There is no diabetes. Diabetes is considered either as moderate risk, high risk or very high risk. So very high risk patients are diabetic patients who are already having established cardiovascular disease, or they are having target organ damage. And what is target organ damage? Target organ damage is either proteinuria or CKD with eGFR less than 30 or left ventricular hypertrophy or retinopathy, or three or more major risk factors. And what are the risk factors? One is age, second is hypertension, third is dyslipidemia, fourth is smoking, and fifth is obesity. So any person who is obese, having diabetes, having hypertension, having age more than 50, considered very high risk. Smoking further adds to that thing, tobacco consumption in any form. Or early onset type 1 diabetes with more than 20 years of duration, then this is being considered as very high risk. Now, moderate risk are young patients, type 1 diabetes, which are less than 35 years of age, or type 2 diabetes less than 50 years of age, with duration of diabetes less than 10 years, and without other risk factors, they are considered as moderate risk. And high risk is patient with diabetes, duration more than 10 years, without target organ damage, but one additional risk factor. So, diabetes duration more than 10 years, one additional risk factor, in absence of any target organ damage, in absence of CVD, they are considered high risk patients. So this is as per the EAC guidelines. Now what they say, they say you target blood pressure, glycemic control, LDL cholesterol, platelet inhibition, smoking, good physical activity, weight, and dietary habits. Blood pressure 130 for most adults, less than 130 if tolerated, but not less than 120. Less stringent targets, particularly for elderly patients. Glycemic control less than 7 HbA1c for most. Younger patients, few comorbidities, you may go for less than 6.5. Elderly patients, short life expectancy, multiple comorbidities, you may go for about 8%. LDL, very high risk, LDL should be kept below 55. High risk, it should be kept below 70. And moderate severe risk, it should be kept below 100. And platelet inhibition in diabetic patients who are at high or very high risk, you should consider aspirin therapy. We will see in subsequent slides. So lifestyle modification is the main form for prevention of cardiometabolic disorders. They are the basic foundation for any therapy to be begun with. Reduced calorie intake is very much important, particularly to lower excess body weight. Mediterranean diet, as shown, evidence of reduction in cardiovascular events in randomized controlled trial, Predimed trial. Therefore, it is recommended that Mediterranean diet supplemented with olive oil or nuts, it reduces the incidence of major CV events. And moderate to vigorous physical activity of more than 150 minutes per week, at least 3 days per week, and there should not be more than 48 hours lapse between 2 episodes of physical activity, and this is being recommended for the prevention and control of that. Glycemic control I have already highlighted, because we know that tighter glycemic control early in the diabetes, it takes a lot of time to have beneficial effects on macrovascular events or cardiovascular events. Generally takes around 20-year time scale. So earlier aggressive control of all CV risk factors is the key for CVD prevention in type 2 diabetes. As far as blood pressure control is concerned, systolic blood pressure to 130, less than 130 tolerated, but not less than 120, diastolic less than 80, but not less than 70. Optimal control for prevention of micro and macrovascular complications. Lifestyle modification is must. ACE and ERB, they are particularly preferred, not for every patient, but in presence of any degree of proteinuria or albuminuria or LVH. If these things are there, then you are justified to give ACE inhibitors or ARBs as per EAC guidelines. And many patients, they require combination therapy where you can combine RAS with a calcium channel blocker or diuretic. And patients should be encouraged to self-monitor blood. Lipid control I have already highlighted. Non-HDL target, if we see it is less than 85 in very high risk and less than 100 in high CV risk. Statins are the first choice. If LDL target is not achieved, one may add ezetimibe, and if required, one may add PCSK9 inhibitor. But PCSK9 inhibitor currently is approved for use in people who are having established atherosclerotic cardiovascular disease or hereditary familial hypercholesterolemia, where statins are not able to reach to the target LDL cholesterol. And it should be considered in patients with type 1 diabetes at high CV risk, irrespective of the baseline LDL cholesterol level as per the ESC guideline. Aspirin, secondary prevention, it is must. If it is a moderate CV risk, aspirin is not recommended. But high or very high CV risk, aspirin can be considered in the absence of clear contraindications, because we all know aspirin is associated with an increase in bleeding episodes. So you have to judge the benefit risk ratio depending on the risk of cardiovascular events and the risk of bleeding. And based on that, you have to decide. But generally, age above 50 years with risk factors, you may think of giving aspirin because here the risk of cardiovascular events are high. You have to keep in mind that elderly people, people who are having renal failure, or those who are already having anemia, they are at higher risk of development. Now you have to use it judiciously. Glucose lowering therapies, I think currently we are knowing that SGLT2 inhibitors and GLP-1 analogs are the therapies which are being recommended not only for glucose control, but they are also recommended to reduce CV events. And the ESC guidelines say that patients with type 2 diabetes, established cardiovascular disease, should be given these drugs. At the same time, they also recommend that the people with type 2 diabetes who are at very high risk or high CV risk, they should be given these drugs to reduce CV events. And the drugs are empagliflozin, canagliflozin, dapagliflozin, of which empagliflozin is recommended to reduce the risk of death based on the data of EMPA-REG. And same way for GLP-1 analogs, liraglutide, semaglutide, dulaglutide, they are recommended in patients with established cardiovascular disease or those who are at very high or high CV risk to reduce CV events. And of these three, liraglutide is recommended to reduce the risk of death based on the leader date. So SGLT2, GLP-1 analogs are also one of the important drugs to be used for prevention of cardiovascular disease in type 2 diabetic patients. This is particularly useful for secondary prevention, but it can also be used for primary prevention in high-risk category patients. SGLT2 inhibitors, even if we know that heart failure is an important component of cardiovascular disease in type 2 diabetes, and SGLT2 inhibitors are therapies which are recommended for primary prevention of heart failure in diabetic based on the data of DECLARE TIMI trial. And now we have got a lot of evidence that SGLT2 inhibitors, they are useful for patients who are having heart failure with reduced ejection fraction, irrespective of the presence or absence of diabetes. So as far as heart failure hospitalization is concerned, SGLT2 inhibitors, they are recommended to lower the risk of heart failure hospitalization and also for primary prevention of heart failure in type 2 diabetic patients. Metformin should be considered if the eGFR is good. GLP-1, DPP-4 inhibitors, particularly sitagliptin and litagliptin, they have got a neutral risk. Insulin treatment may be considered. Saxagliptin should not be used, and glitazone should not be used. That we all. So this is the first time ESC has come out with this algorithm that if the patient is having already very high CV risk or established cardiovascular disease and they are drug newly diagnosed type 2 diabetic, you may straightway start with SGLT2 or GLP-1 monotherapy, and then if required, you may add metformin. So this is the first time any organization has come out that you can start with a drug other than metformin as first-line therapy in type 2 diabetes. Otherwise, most of the organizations, they say that you have to start with metformin, and if there is a compelling indication, you may give SGLT2 or GLP-1, but metformin should be there unless and until it is contraindicated. But this is a different way of approach by ESC. And if the patients, they are already on metformin, then you should first add SGLT2 or GLP-1, and then if required, you may add other agents. So this is the flow chart. One may go through the entire article, which is there in European Heart Journal 2019. Now we will come to Canadian guidelines 2018. This is also a good document. So currently they said that there is no current risk model which can reliably exclude people with diabetes who are unlikely to benefit from long-term CV protection strategies. So most people with diabetes, they are very likely to benefit. So use of risk scores in diabetes is currently not being recommended by Canadian guidelines. And most of the time we see that risk scores which are developed, they are for Western population. So in our Indian population, the risk scores, they don't fare better. So it is better to judge whole CV risk depending on the presence of risk factors, and it is better to target all CV risk factors simultaneously for prevention of CVD in type 2 diabetes. Antiplatelet, also they have said that routine use is not recommended, but multiple CV risk factors you may use. ASA 75 to 162 milligram is for secondary prevention. It is definitely there. And if patient is intolerant to ASA, then one may use clopidogrel. Smoking cessation is must because smoking is associated with very high risk of MI, stroke, and progression of renal disease, and also it is associated with poor glycemic control. And if you stop smoking, there is definitely a decrease in cardiovascular mortality and cardiovascular risk in these people with diabetes. RAS blockers, previously in 2013, Canadian people, they have recommended that anybody who is having diabetes above 50 years of age, one risk factor, irrespective of presence or absence of hypertension, irrespective of presence or absence of albuminuria, they should be put on SC or ARBs because they provide benefit. But now they have come out that S inhibitor or ARB at doses that have demonstrated vascular protection. This is very important because you have to use it in a given dose. Should be used to reduce severe risk in adults with type 1 or type 2 diabetes with any of the following. Either the patients they are already having clinical CVD or age 55 years or above with one additional severe risk factor or end organ damage, that is albuminuria, retinopathy or LVH, and microvascular complications. If the patient is already having microvascular complications, you may think of using these agents for prevention of cardiovascular events in these patients. Lipid control, it is almost same. If there is a clinical CVD, age is more than 40 years, age is less than 40 years, and one of the following, that is diabetes duration is more than 15 years and age is more than 30 years, or microvascular complications or presence of other CV risk factors, all these people, they benefit from statin therapy as per Canadian guidelines, and this is irrespective of type of diabetes. And if you are not able to achieve LDL cholesterol goal, then you may use second line agents like ezetimibe or PCSK9. Glucose lowering therapy is indicated, and they also say that SGLT2 inhibitors and GLP-1 analogs with demonstrated CV outcome benefit in dedicated cardiovascular outcome trials should be added to reduce the risk of further cardiovascular events. Now come to ADA. So the ADA says that the 10-year risk of a CVD event should be assessed using the race and sex specific cohort equations to better identify people who are at high risk of cardiovascular events. Pre-diabetes is also associated with increased CV risk. So every patient who is having pre-diabetes, other CV risk factors should be searched for, and they should be targeted. Everything should be targeted simultaneously in an intensive manner so that future risk of cardiovascular disease can be minimized or prevented. This is the ACC AHA guidelines, and they say that diabetes mellitus and age 40 to 75 years justified to use moderate intensity statin therapy. They also, that 2019 guidelines of the ADA also advocate high intensity statin therapy in people who are having a CVD risk score more than 20% or who are having multiple CV risk factors with age more than 50 years and who are having established cardiovascular disease. Then you have to use high intensity statin therapy. And this is the model which they have suggested, that assess patient characteristics, then consider specific factors that impact the choice of treatment and shared decision making. Then you start management, implement management, ongoing monitoring, and then review and further agree on targets. So this is just like the RSSDI therapeutic wheel, which is being proposed by Endocrine Society of India and RSSDI together, where they are taking a wheel. Is there an A, B, C, D, E, F, G, H number of factors you have to consider, and for a given patient you have to choose the most important factors, and depending on those factors you have to decide therapy that will be suitable for your patient. So this is the way you have to individualize treatment as far as type 2 diabetes management is concerned. And here also they have said that if there is a ASCVD or heart failure or CKD, then SGLT2 inhibitors or GLP-1 analog should be preferred. Sorry for the bad quality of this slide. So why SGLT2 and GLP-1? I will focus more on SGLT2 because they are oral and much more within the reach of common man in our country. So I will focus more on SGLT2 inhibitors. So they have got a lot of metabolic effects and non-metabolic effects. We all know they decrease glucose, they increase HDL cholesterol, decrease triglycerides, decrease uric acid, decrease body weight, particularly body fat, and importantly visceral fat. They increase glucagon and ketones, and mild ketonemia is also being suggested as a way of improvement in heart failure because they improve the myocardial fuel energetics. Intracellular sodium is decreased, metabolic flexibility is improved, mitochondrial biogenesis is improved, and cell dormancy is improved. Non-metabolic effects, they decrease inflammation, they decrease fibrosis, blood pressure, they decrease arterial stiffness, decrease plasma volume, beneficial effects on albuminuria as well as on renal function. So these are variety of metabolic, non-metabolic effects of SGLT2 inhibitors. And SGLT2 inhibitors, they act upon all the components of the metabolic syndrome, starting from visceral obesity, hypertension, diabetes, high triglyceride, low HDL, hyperuricemia, non-alcoholic fatty liver disease, renal disease, all the things, SGLT2 inhibitors, they have got a beneficial effects on all these aspects. If we compare SGLT2 with GLP-1 analogs, this is an article published in Journal of the Endocrine Society in 2020, where they say that as far as major adverse cardiovascular events are concerned, both are almost equivalent. But if we see the number needed to treat to prevent one event is less with SGLT2 as compared to GLP-1, but both are more or less equivalent. CV death, if you see, then GLP-1, it requires 141 to patients to be treated to prevent one CV death. For SGLT2 it is 200, so almost equivalent, marginally better for GLP-1, but it is almost equivalent. If you see heart failure hospitalization, then they fare far better than GLP-1 analogs. And here the number needed to treat to prevent one event is 91 with SGLT2 and 500 with GLP-1 analog. And if you see the renal outcomes, here also the SGLT2 inhibitors, they are better because number needed to treat is 50 with SGLT2 and 67 with GLP-1. GLP-1 are also having some renal protective effect, but SGLT2 inhibitors are here also beneficial, and they not only reduce albuminuria, but they also have beneficial effects on progression of diabetic kidney disease as per the data available. And this is a real world data as far as SGLT2 and GLP-1 are concerned. This is real world data just published in 2020 in BMG Open Diabetes Research Care. If you see 3-point MACE, SGLT2, although the P interaction is not significant for anything, but the results are as compared to GLP-1 as far as 3-point MACE, heart failure hospitalization and revascularization and hospitalization for CVD, they are concerned. So SGLT2, they are better molecules. GLP-1 are also good molecules, but they are costly, they are injectable, and there are multiple, particularly the GI side effects are there, which may result in withdrawal in many of the patients. If this is one of the data related to GLP-1 withdrawal, what are the reasons for that? And that we all know that patients, physicians, both they prefer oral drugs, and if oral drugs they are able to provide cardiovascular protection, they should be preferred. That is what the common sense approach says. But still, GLP-1, they are also very good molecules, GLP-1 analogs, and that should be used in a patient's, particularly when the eGFR is less than 30. Still SGLT2 inhibitors, they are not recommended to be used in those kind of patients. Probably the guidance may change in coming months or coming year because of the data available from DAPA-CKD, and now the other SGLT2 are also having data in CKD patients. So probably the guidance may change, but currently GLP-1 analogs are to be used in those category of patients. Also people who are having severe obesity, because GLP-1 analogs, they are associated with risks, and therefore that should be preferred where weight loss is one of the important outcome measure for type 2 diabetic patients. Then GLP-1 analog should be preferred over SGLT2. And if cost is not a problem, one can combine both the agents together and get all the benefits which are there from this two agents. Also SGLT2 inhibitors, there are side effects in the form of genital mycotic infections. Hypoglycemia is not common unless and until there is sulfonylurea or insulin. UTI is also rare. Fracture, amputation, one should keep in mind, but currently there is no evidence to say that they increase the risk of fracture or amputation, but pharmacovigilance is required whenever you are using these newer therapies for your patients, particularly for cardiovascular protection. So this is a suggested approach by one of the papers, that if young patient, short diabetes duration, no microvascular complications, you use therapies which do not increase weight, which do not increase hypoglycemia, and which provide long-term protection. So better to use newer therapies, SGLT2 inhibitors, for prevention of chronic kidney disease or for prevention of diabetic kidney disease. However, the evidence is still not strong for primary prevention of cardiovascular disease or renal progression in patients who are not having albuminuria, other things, because most of the trials, they are carried out in people who were having either albuminuria or impaired renal function. So patients who are not having that, whether giving SGLT2 will prevent those complications, it is just hypothetical, but one can use these agents because they are having so many pleiotropic benefits. If there is an impaired kidney function, SGLT2 are preferred. High cardiovascular risk, one may use either SGLT2 or GLP-1 analogs. History of CV disease, ASCVD, SGLT2 or GLP-1 analogs, heart failure, then SGLT2 are preferred. Same way, this is another algorithm which is being suggested by Bonaventura in Journal of Internal Medicine in 2019. Although this was based at that time, some of the trial results were not there, and they have used sulfonylurea as a glipizide. But nowadays, we use sulfonylurea, which has got very good CV safety analysis, that is glimepiride, and which has got very good long-term data also in VADT follow-up study. So glimepiride is nowadays being used much more frequently in sulfonylurea arm, or gliclazide modified release, that has got good evidence as on the basis of advanced data. So those two sulfonylureas we can use in our type 2 diabetic patients, but not glipizide or glibenclamide. So these are the algorithms which are suggested by various persons. But if we stick to guidelines, then anybody who is having established cardiovascular disease or heart failure, or at high risk of heart failure, or already established chronic kidney disease or diabetic kidney disease, then they should be given SGLT2 inhibitors or GLP-1 analogs, irrespective of HbA1c and irrespective of ongoing diabetes therapy. So even if the patient is on any therapy, if HbA1c is 7 also, this agent should be given because they provide cardiorenal protection in this kind of patient. Now we will come to how this is all guidelines, what they say. So what is really going on in a clinical practice on a global scale? So this is data from the TECOS trial, where they've tried to find out how the clinicians they are faring as far as secondary prevention of CVD in type 2 diabetic patients is concerned. So they have selected around 13,000 patients who were having known CVD at entry in this trial, and this was from 38 countries, and they've tried to find out how many people they were on 5 secondary prevention measures, that is aspirin use, lipid control or statin therapy, LDL less than 70, blood pressure less than 140/90, ACE or ARB use, and smoking cessation or non-smoking status. How many people they were following these 5 measures for secondary prevention, or they were at targets of this thing for secondary prevention of CVD because they were already having established cardiovascular disease. And this is the data. Only 30% were having all the 5 parameters. Almost 72% they were having at least 4 parameters. North America, highest people were having all 5 parameters, 41%. Other regions, almost 25%. Smoking cessation was achieved most, and blood pressure control was the least as far as these 5 parameters are concerned. And they have tried to find out those patients who were following all 5 measures as compared to those who were following 2 or less measures. The risk of cardiovascular disease was much lower in those who were following all 5 measures. That was reduction to the tune of almost 40%. So this says that there is definitely a large gap. Still, we are not using these therapies adequately for prevention, even for secondary prevention of CVD in our type 2 diabetic patients who are already having established cardiovascular disease, and we need to focus more on these things so that we can improve cardiovascular risk in our type 2 diabetic population. And there is definitely a clinical inertia, particularly as far as the use of these new glucose lowering agents, which has got cardiorenal protection, that is SGLT2 and GLP-1. This is a good paper published in 2020, and which says that there is a lot of clinical inertia about the use of these new agents. And they have suggested that this is the approach ABCDEFG through which one can improve the use of this new glucose lowering medications, not for blood glucose control, but for cardiorenal protection in our people of type 2 diabetes who are already having established cardiovascular disease or who are at high risk of cardiovascular disease. So I think we need to learn more, and we need to implement our knowledge in our clinical practice so that we focus more on CVD risk factors in our type 2 diabetic patients. We have to move from glucocentric to glucovasculocentric approach or holistic management of type 2 diabetes. That is what is required currently in our clinical practice. And that's why the World Heart Federation has come out with this roadmap, and they are working on that patients with type 2 diabetes can be divided in 2 groups, with CVD, without CVD, and then they have developed various protocols to be followed so that we can reduce cardiovascular or risk or events in these people who are living with diabetes. And they say that we need to have an integrated approach by involving healthcare systems, patients themselves who are having diabetes, and public health policy makers. And this can be done only with collective action, including research, collaboration, communication, education, advocacy, agency, and leadership. And with that, we can try to modify CV risk factors in our type 2 diabetic population and reduce their risk of cardiovascular disease. So this is a very good suggestion by 2018 Canadian guidelines, that is ABCDES approach, and this is for CV protection in people with diabetes. A is A1C, usually less than 7. B is BP less than 130/80. Currently, it has been modified to 140/90, but people at high risk, you should go for less than 130/80. Cholesterol LDL less than 70, preferably use statin. If very high risk, it should be less than 55. D is drugs to protect your heart, that is statins, S or ARBs, and SGLT2 inhibitors or GLP-1 analogs. And E is exercise and eating, regular physical activity, healthy eating, maintenance and achievement of a healthy body weight. And S is stop smoking and manage stress. And if we target all these things in our diabetic patients, then we can give them life free of not only microvascular complications, but also we can reduce the risk of cardiovascular events and cardiovascular complications in our patients and give them long life, long healthy life free of complications. How to manage dyslipidemia in diabetic child 8 year? I think this is a very controversial thing. So if a child is having dyslipidemia at the age of 8 years, if type 1 diabetes is there, and if type 1 diabetes is not controlled, first you go for a good glycemic control, and then depending on, there is a very good guidance from ADA about this dyslipidemia approach in children, and you can go through that document and can see whether the patient fits for therapy or not. But generally, statins, they are not recommended below 12 years of age. So better is to have a healthy eating, good exercise, and good glycemic control, because many of our type 2 diabetic patients, many of our diabetic patients who are having uncontrolled hyperglycemia, they are at risk of having high triglycerides, and that can be controlled by achieving a good glycemic control. How about usage of saroglitazar and fenofibrates? When to add which? So I think currently saroglitazar is recommended only for hypertriglyceridemia, lowering of triglyceride levels. Fenofibrate, if we see, although the trials which were conducted with fenofibrate, they have not shown statistically significant reduction in cardiovascular events in people who were having high triglyceride levels. But there is a meta-analysis which suggests that, particularly in type 2 diabetic patients who are already on statin and who are having high TG and low HDL, so triglyceride levels more than 204 and HDL 42 or less than 42, then this is atherogenic dyslipidemia. And meta-analysis says that if you use fenofibrate in these people, then you may reduce the risk of cardiovascular events further by the tune of 20-25% as per that meta-analysis. So one may think of using fenofibrate for cardiovascular reduction in such category of patients. Otherwise, for reduction of triglycerides, fenofibrate or saroglitazar, any of them can be used. But whether that will translate into cardiovascular benefits or not is still controversial. And now we have got EPA, that is the trial has shown that EPA in people who were having high triglycerides on the top of statin therapy, it reduced cardiovascular events. So it has been suggested by some of the organizations that you may use EPA, that is icosapent ethyl 4 gram daily, for reduction of triglyceride to reduce cardiovascular events in type 2 diabetic in patients who are already on statin therapy. That is there. For diabetic dyslipidemia, we have to add drugs from day one or wait for a month or so to settle it down. Generally, if the patient is having uncontrolled blood sugar values, then that contributes to dyslipidemia. So better is to have a good glycemic control or reasonable glycemic control, and then to do lipid profile, and then to decide about therapy. But nowadays, the suggestion is not to go for lipid levels. Depending on the CV risk, you have to use statin. So if, as per ADA, if anybody is having age more than 40 and having diabetes, irrespective of lipid profile, they should be given moderate intensity statin therapy because that gives them cardiovascular protection. And then you can do lipid profile to adjust the dose of statin therapy, whether you have reached LDL cholesterol target or not. So most of the guidelines, they now say that irrespective of baseline lipid profile, depending on the cardiovascular risk, you have to give patients statin therapy, and then lipid profile should be done to monitor the response to statin therapy and to adjust the dose of statin therapy to reach LDL cholesterol target. How to manage dyslipidemia in GDM, lady? I think in GDM or during pregnancy, statins are contraindicated, and there is no suggestion that you go for measurement of lipid profile or management of lipid dyslipidemia during pregnancy, because the only treatment is statins, which reduces cardiovascular events, and that is on a long-term basis. So during 9 months period, I think there is no other way that you can modify. Only dietary intervention is the key. When is aspirin given primary prevention in GDM and how long? So I think GDM in primary prevention, I think this is somewhat is it GDM or type 2 diabetes? In GDM, aspirin for primary prevention in GDM, I am not able to understand that question. But type 2 diabetes, aspirin for primary prevention is currently not recommended. Only in people as per ESC, those who are high risk or very high risk, you may think of using aspirin for prevention of CV events, but you have to keep in mind the bleeding risk, and you have to avoid in population who are at high risk of bleeding, like elderly people, renal failure, those who are on multiple therapies or already having gastrointestinal manifestations. Then the risk of GI bleeding is high. Normal lipid levels, statins indicated, yes, because unless and until LDL cholesterol is less than 70 in your type 2 diabetic patient, most of the time you target less than 70. So if the patient is already without anything having LDL cholesterol of 60, it is better. But ADA says that you do not go by the baseline LDL level. Give them statin. Moderate intensity statin is beneficial. However, this is a very tricky and controversial area. So you have to discuss benefit risk with your patient. But statins, they are much better to be used in diabetic patients for CV risk reduction. There is a question from Dr. H.S. Das that 50-year-old man non-diabetes and AMI on metformin 1 gram twice daily, HbA1c 8.5. What should be the next medication? It should be empagliflozin, because this is a compelling indication. Patient is already having acute cardiovascular event, and nowadays they say that there is still the people, they say that whatever trials were there, the patients were enrolled after 3 months of an acute event. So because of that, other things that can happen in immediate post period of that acute event. So if that time has gone, you may definitely put them on either empagliflozin or GLP-1 analog, depending on the renal profile and other things. That is a compelling indication. You should give any patient who is having established cardiovascular disease and diabetes, irrespective of treatment, irrespective of HbA1c, should be given SGLT2 inhibitor for cardiorenal protection. Antiplatelets to be used in only CVD established patients or in every diabetic. I think aspirin or antiplatelet are currently being recommended for secondary prevention. So patients who are already having CVD, you have to give them antiplatelet. For primary prevention, patients who are having multiple CV risk factors as per ADA, if the age is more than 50 and patients are having additional CV risk factors and the ASCVD risk score is high, then you may think of aspirin, provided the patient is not having risk factors for bleeding, because aspirin, previously aspirin was considered a hero. It has got no side effects and it can be given to any person. But no, the current evidence says that aspirin is associated with increased risk of bleeding events, and that is a real thing. It has been proven in almost all the trials which were conducted with aspirin for primary prevention, be it Ascend or Arrive or Esprit, which were conducted in elderly people, in diabetic population or in non-diabetic population. Everywhere aspirin, when used for primary prevention, risk of bleeding was increased. So basically it is to be used for secondary prevention, patients who are having CVD. For primary prevention, one can use it, but then you have to keep your fingers crossed, because the risk of bleeding is there and you have to use it with a caution. Only when the CV risk is high, then you have to use. GDM lady with bad obstetric history, can we give aspirin? I think aspirin is being used for in obstetric management. Aspirin is used for prevention of that preeclampsia and various other things. So I am not an expert to give any idea about that thing. It is better that you ask some gynecologist or obstetrician about that thing. Patient of fatty liver with dyslipidemia, do you recommend correcting dyslipidemia or treating fatty liver? I think if fatty liver dyslipidemia is there, dyslipidemia should be corrected. What is treatment for fatty liver? Currently, there is no approved treatment for fatty liver. However, saroglitazar has been recently shown to have beneficial effects in patients who are having non-alcoholic steatohepatitis. So in that category, you can use saroglitazar, you can be used, but still officially no drug is approved for treatment of non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Pioglitazone, vitamin E, all these things are tried and there are various protocols. But if the patient is having fatty liver with dyslipidemia, lifestyle modification is the key. And if there is, you have to calculate CV risk, and if CV risk is high, then you are justified to give them statin. Statin intolerance with dyslipidemia, how can we manage? So whenever the patient is having statin intolerance, you have to stop it for time being. You have to start with a low dose and gradually increase the dose. Sometimes you have to change from atorvastatin to rosuvastatin. If patient is not tolerating, one may try with pitavastatin, which has shown some benefit in people who were not tolerating statins and they were able to tolerate pitavastatin. And also there are trials to support alternate day use of statin therapy in people who are not tolerating, and still the LDL cholesterol reduction was maintained. So all these things one can try with, but when statin intolerance is there, stop it, start with a low dose, gradually increase, do not go to the maximum dose, keep it in between, or you may use another statin. That is general practice which is being done. Thank you everyone for attending this program.